All right, good afternoon. Welcome to another VCBH lecture. And today we're fortunate to have Brandon Marshall from Brown University, who's going to talk to us, as you see in his slide, about the opioid overdose crisis. So a topic that's certainly on our minds and people throughout the U.S. So I'm very much looking forward to that. We have actually one housekeeping matter. So when you have questions, please send them through the Q&A button, but save them till the end, and then we'll have Dr. Marshall answer them at that time. So to make sure that Dr. Marshall has the time he needs, I'm going to step out of this and turn it over to my colleague, Tom Ahern, who is a cancer epidemiologist here at the University of Vermont, and actually was smart enough to recommend that we invite Brandon to come and give a lecture. So Tom?
Thank you, Steve, and good afternoon, everybody. It is a privilege to introduce Dr. Brandon Marshall, Associate Professor of Epidemiology at the Brown University School of Public Health. He received his PhD in epidemiology from the University of British Columbia and completed postdoctoral training at Columbia University. Dr. Marshall's research focuses on substance use epidemiology, infectious diseases, and the social, environmental, and structural determinants of health in drug-using populations. He's the PI of multiple NIH and CDC funded projects in this domain and has published more than 250 scientific papers. Dr. Marshall is also Scientific Director of Prevent Overdose RI, Rhode Island's Drug Overdose Surveillance and Information Dashboard. In this role, he works with the Rhode Island Department of Health to track, measure, and evaluate efforts to address the state's overdose epidemic. He also serves as expert advisor to Governor Gina Raimondo's Overdose Prevention and Intervention Task Force. As you're about to hear, the scope and impact of Dr. Marshall's work is nothing short of astonishing. His talk today will largely focus on his observational research, but he will briefly touch on recent forays into interventional studies, and he'll be happy to elaborate on those studies during the Q&A session and while meeting with students. Dr. Marshall, while we wish we could welcome you to Burlington in person, we're grateful that you could join us virtually today. And I'll turn the floor to you.
Thank you so much, Tom, for that lovely introduction. How's the audio? Can you hear me okay? Great,
yes,
excellent.
Yes,
I love Vermont. I wish I could be there in person as well, but I'm very happy to have this opportunity to share some of my work and my team's work with all of you today. So I'm going to start with the numbers, which are shocking. Drug overdose deaths continue to increase in this country year over year after a brief blip in 2018. Every day, almost 200 Americans die of a drug overdose. So mortality from drug overdose has actually never been higher. 2020, which I'll come back to at the end of the lecture during the COVID-19 pandemic, looks actually to be even worse than 2019. The data from the CDC is still provisional, but almost certainly more than 80,000 people will have lost their life to a drug overdose in this past year. So unfortunately, this trajectory continues to be exacerbated during COVID-19, which I'll come back to at the end. When we look down and start to drill down into the specific drugs that are involved in these deaths, we can understand a couple of more recent patterns. There's two here that I want to note. This figure is from the most recent national CDC report that just came out a couple months ago. The first is that deaths from heroin and prescription opioids, I would say since 2013, are broadly stable. That's shown by the solid line and the large dashed line in the figure. It's something I like to highlight because we continue to have a prescription opioid overdose epidemic in this country, and that's shown in that figure there. They have not gone away. They've simply been eclipsed by deaths involving synthetic opioids, predominantly fentanyl, which is the smaller dashed line, now the main driver of drug overdose fatalities in this country, and more recently increases in cocaine and methamphetamines or amphetamines, what is termed here psychostimulants with abuse potential. Many of these also involve a synthetic opioid such as fentanyl as well. So the drugs that are involved in deaths is continuing to change and evolve throughout this crisis. The types of populations most heavily affected continues to evolve as well. This is from a study we just published last year in International Journal of Drug Policy. We used national data to look at age and space trends in drug overdose mortality between 2009 and 2018. And this animation, I think, shows a couple of really important pieces. The first is the red versus the blue. Drug overdose mortality has increased the fastest in states east of the Mississippi River, and that's because largely of the introduction of fentanyl in the illicit drug supply in these states. But we have seen more recent increases in Western states as well that's not reflected in this slide. The second is this bimodal distribution that we see, where we see high rates in, say, the 50 or a peak in the 50-year-old age group. This age group typically is where we continue to see those prescription opioid deaths, benzodiazepines, alcohol, other prescription medications playing a role. But then that fastest increase in the younger age cohorts, say peaking around 30 to 35, really spiking up in the last couple of years, particularly in those eastern states. And that, again, is due to the introduction of fentanyl in illegal opioids, but also stimulants, as I mentioned. What's not shown here is that overdose rates are increasing the fastest for young Black and Latinx people in this country, both in Western and Eastern states. So there's a lot of interesting dynamics here. The drugs involved in overdose is shifting. The people and the places most heavily affected is also evolving. But what's, I think, important to note is that at a macro level, we are on this exponential trend. This is a powerful paper, I think, that came out several years ago in Science that looked back a little bit farther in time, way back to 1980, and showed that mortality rates due to drug overdoses have been increasing almost perfectly exponentially for over 3 decades. And I just added the 2019 figure last night. This was my best attempt at mapping where that 2019 figure might be. And you can see we're largely still on this trajectory today. So the question that's been nagging me for the last couple of years is why? Why, despite all that we're doing, do we continue on this incredibly alarming exponential trajectory in drug overdose mortality in this country? So I'll hope to provide a couple of insights on this point today. But drug overdose death is not the only endpoint that I want you to think about throughout this presentation. We also have millions of people who are suffering from what we call opioid use disorder, which is a problematic opioid use. In fact, we are an exception internationally. Between 2.6 and 3 million people in the United States suffer from opioid use disorder. That's the highest in the world. The only countries that are really comparable would be in the Middle East, Iraq, Iran, and Afghanistan, as you can see in this figure that we published in a Nature review just last year. This is using data from the Global Burden of Disease study. So we have an incredible drug overdose crisis, but also an incredible high morbidity due to opioid use and opioid use disorder in this country. So that's the background. So these are today's objectives. So I want to spend some time thinking about what are these underlying sociostructural and environmental determinants of this trajectory. And I don't have the full answers, but I'll hope to provide you with a couple of insights on what I think are some of the drivers. And then I'll talk about some strategies to reduce overdose deaths, providing more a framework for thinking about how to reduce mortality from accidental drug overdose. And then, as I mentioned, I'll finish talking about the impact of COVID-19. So what are some frameworks that we can think about to understand the fundamental drivers of the overdose crisis? A common one was coined by Case and Deaton, which is called the deaths of despair. And this was from a paper they published showing over here on the right that mortality rates overall in US whites has been largely stable, actually increasing over the last several decades, which is in stark contrast to most other developed nations and also other groups in the US, including US Hispanics, which is shown in dark blue. And the proximal reason for this, they hypothesize, is increased use of alcohol and drug use, particularly in white working class populations, that's linked in turn to pain, increased rates of disability, social isolation, and depression. I think there's a couple of problems with this framework that I want to highlight. The first is that it, in my view, over-individualizes the problem. It focuses on those very proximal causes that occur at an individual level. Although to their credit, if you read the whole paper, they do talk a little bit about how economic instability and financial security is an underlying driver potentially of these mechanisms. That's often not highlighted in the popular understanding of this hypothesis. The second problem, I would say, is that despair associated with drug use is actually not a new concept. The crack and heroin epidemics of the 20th century were largely concentrated in structurally disadvantaged communities of color, in which lack of employment and educational opportunities, police brutality, and other effects of systemic racism were linked with increases in drug-related harm. So this is actually not a new concept at all in the United States. And that's really the second problem I see with this, is that it centers the experience of the white working class in the United States, sort of downplaying or ignoring the fact that Black and Brown communities in this country have been greatly and adversely impacted by the war on drugs and other racist drug policies for over a century. So I want to propose another framework that's helped me in my thinking. This is a rather old one at this point, but it shows us, it posits that the health and social harms from drug use are a function of how we choose to regulate drugs. Basically, we have two polar spectrums here: prohibition, where we see a maximization of illegal profits that are largely unregulated, and in turn, maximization of health and social harms from an illegal market. And on the other side, which I would argue is akin in some ways to the US medical system, we have unregulated legal profits, or perhaps insufficiently regulated legalization and promotion of medical substances, including prescription opioids. So we can debate a lot about how we could use different public health policies to minimize these health and social harms. What I want to focus on, though, is that we've chosen a path in this country of the polar maximums, right? We have prohibition of some substances, which in this framework leads to maximization of harms due to drugs that we've chosen to deem illegal. And then what I will argue is also a medical system which in many ways maximizes and has maximized profits over patient safety. And these two polar opposites also interact with each other as well. The large, enormous supply and demand for opioids that was created by pharmaceutical manufacturers in the late 1990s and early 2000s, when policies were put in place to restrict that supply, the illegal market filled that demand, and that has led now to the heroin and now fentanyl related deaths that we see. So I've been really interested in repositing some of these problems as deaths of corporate malfeasance, and also, say, insufficient regulation of corporate actions in this prescription opioid space. So what does the data actually look like here? Well, this was a study we published in The Lancet a couple of years ago with some international colleagues, summarizing what we see here are standardized daily doses of opioids per million people per day. And it won't surprise you to know that the United States has by far the world's highest per capita prescribing of prescription opioids. Even after peaking in 2012, we continue to have a much higher opioid prescribing rate than any other country by far. So what drove this? I'm sure many of you are familiar with the actions taken by the pharmaceutical industry to promote these medications, and lots of other actors playing a role as well in creating this problem. With some colleagues, namely Scott Hadlin and Magda Serta, also at BMC and NYU, we focused on one particular piece of this entire ecosystem that created this high rate of opioid overprescribing. And that was the perfectly legal marketing of these products directly to physicians and other providers, which is legal in this country. Pharmaceutical manufacturers can promote their products through a number of different mechanisms, as you'll see, primarily through free meals, lectures, sponsored events, and so forth. These data are actually all tracked, so we were very interested in understanding and mapping this. This was the first study we published using these data, which are publicly available in what's called the Open Payments Database from CMS. You can go and you can download physician-specific information on how much the total dollar and the types of marketing that every licensed provider received in this country, and for specific products and from what manufacturers. So we looked specifically at opioid manufacturers and found that over a period of about 2.5 years, from 2013 to the end of 2015, there were over 375,000 payments to physicians related to opioid-specific marketing, which touched over 68,000 physicians, which was about 1 in 12 actively licensed physicians at that point. So an incredible penetration, a very large number of providers receiving some sort of marketing, as you'll see, mostly free meals. So this is looking at the distribution of the payments and the types of payments. You can see the median amount, the dollar figure of this type of marketing was very small. Most of it was, speaking fees or honorarias and food and beverages at different lectures and events. 94% of the payments were for free food and beverage. So you might ask yourself, would that really influence prescribing, saying getting a free meal at an event? Would that have much of an impact on opioid prescribing? So that's what we sought to answer in the next paper. So this was the follow-up paper, which we published in JAMA Internal Medicine, that extended this work. We were interested in understanding what the effect of this marketing was on opioid prescribing. So as I mentioned, the open payments data is a named physician data set. You can go and you can search for specific physicians. We then found another database, which is also a physician database of all providers prescribing under Medicare Part D. So it's a subset of physicians who in 2015 had prescribed an opioid under Medicare Part D. And we essentially linked these two databases together. And what we found, at least in this subset of physicians, was that around 7% who had prescribed under Medicare Part D in 2014 received some kind of payment specific to opioid marketing, around $9 million in total value. And what we found in a regression model was that even after adjusting for prior prescribing history and other changes, physicians who received at least one payment had a 9% higher rate of opioid prescribing in the next year in 2015. So it's a little bit hard to differentiate the cause and effect here, because in fact, we know that opioid manufacturers did target high volume providers. Nonetheless, we at least tried to differentiate it to look at payments in 1 year and how that impacts prescribing in the subsequent year, and we were able to identify this effect, which doesn't seem really small, right? Until you actually start to look at some of the detailed trends. I thought this was one of the most shocking results from the paper that really blew me away. We were able, using the data, to look at the number of meals reimbursed in 2014, again, specifically related to opioid product marketing, and then the number of opioid claims in 2015 in total over an entire year. And this really shocking dose response curve. Basically, the more meals that a provider had reimbursed that was related to opioid marketing, the higher number of claims for a prescription opioid in the subsequent year. So I'm arguing here that even low value interactions between pharmaceutical manufacturers and providers are at least associated with increased rates of opioid prescribing. So, what do we learn here? This practice it's less common now, but it was widespread, and it does appear to have very much led to higher rates of opioid prescribing. This was the final paper we did in this series that was an ecologic study. So it was actually looking at the county level, where we looked at the association of this type of marketing with mortality from prescription opioid-related overdoses. So here what we did was we aggregated the open payments data set to the county level, and then correlated that with prescription opioid overdose mortality rates from the CDC. And what we found was, in fact, yes, there is a county level association. We looked at 3 main exposures here. The overall value of the payments per 1,000 population per year in a county was associated, you'll see there in Model A, with a higher rate of prescription opioid overdose deaths. The total number of payments, so not just the value, but the number of interactions or transfers of value, they're called, was also associated with higher prescription opioid overdose mortality at a county level. And what was actually most robust in some sensitivity analyses was the number of physicians receiving payments in that county. We also conducted a mediation analysis that looked at whether this relationship was mediated by county level opioid prescribing rates. And what we found was that Model C in particular, we observed a significant mediation where the relationship between the number of physicians receiving payments and prescription opioid overdose mortality, about 30%, 27, 26% of that relationship was mediated by county level opioid prescribing rates. So an ecologic study, but nonetheless, mapping out this relationship in terms of the actions of pharmaceutical companies influencing providers, which in turn correlating to more opioid prescriptions and subsequently prescription opioid overdose deaths. So I want to move on now to some of the other determinants that I've been interested in investigating. This is using Rhode Island data in collaboration with the Rhode Island Department of Health and some other colleagues here in Rhode Island. I've been very much interested in elucidating what I think are some under-recognized or understudied determinants of overdose. We tend to think about it just as the drug, which is, I would say, a necessary but not sufficient cause of drug overdose would be drug use. There's a lot of other factors there that we actually don't fully understand. So this is one paper that aimed to do this. I have another one as well for you. This paper tried to interrogate what is called the check effect. For folks who aren't familiar with this effect, what we typically see in many settings is that overdoses increase, they spike just after the first of the month for around the first, say, 3 to 7 days of each month. And that's actually what we see in the Rhode Island data as well. You'll see in a moment. And many researchers hypothesize that as being due to what's called the check effect, which is basically that individuals typically receive public assistance, such as TANF or SNAP benefits, at the beginning of the month, and that extra income leads to additional drug use, which leads to increased overdose. So we wanted to interrogate that hypothesis a little bit. We hypothesized that if that is true, we should see these overdoses increasing at the beginning of the month in areas of the state where there's a high level of receipt of public assistance benefits. So that was our hypothesis for this study. So what we did was we looked at 838 overdose deaths occurring in Rhode Island between a 3-year period. This was using a medical examiner data. And we didn't have a lot of information at an individual level on the decedents, just some basic sociodemographic characteristics, which is shown here, and then, but very detailed information on where these deaths actually occurred, which we leveraged for the spatial analysis, which I'll show in a moment. But these are the some basic characteristics that I'll show you here. Looking at total overdoses, sorry, it's 840, not 838. And then the number of overdoses occurring in the first 7 days of the month over this entire 3-year study period, and the number of overdoses and their characteristics in the last 7 days of the month. And what we found was, in fact, yes, in Rhode Island, there's about a 17% increase in the rate of overdoses during the first 7 days of the month compared to the last 7 days of the month. And that seems to be particularly heightened in people in, I would say, middle age, 45 to greater than 55, you can see, and the effect also a little bit more so in women. So that just gives you an idea of what we're seeing in the data. So then what we did was mapped these cases. As I mentioned, we had address level information on where these overdose deaths actually happened. And we used what's called a spatial scan statistic to identify statistically significant spatiotemporal clusters of overdose deaths that are occurring in the first 7 days of the month. So basically what this method is doing is looking at a random distribution of overdoses, well, in proportion to the population density, and then comparing that to the distribution that's actually observed. And what we see here were 2 clusters. That is 2 areas of the state where there was statistically significant higher counts of fatal overdoses during the first 7 days of the month compared to what would be expected based under that null hypothesis of a distribution just in proportion to the state's population. So those 2 clusters are in Woonsocket and Central Falls and Pawtucket for people familiar with Rhode Island. For some reason, the journal made us highlight Providence. I'm not sure why, so that's just why it's in yellow. So then what we did was we examined the neighborhood characteristics of census block groups in these clusters and just looked at the characteristics of census block groups in those 2 red clusters compared to the census block groups in the rest of the state. And what we found was that these census block groups have a higher proportion of African-American residents, have a higher proportion of residents in poverty, and have a higher proportion of residents who are housing cost burden. That is, more than 30% of their total income goes towards housing costs. What we did not find is that these neighborhoods were not those that typically have a high proportion of people receiving public assistance. You can see there was no relationship. So that got us thinking, right, what could actually be driving this? Well, during the first of the month, what else happens? Rent is due, threat of evictions are happening. And so that could be another driver that's essentially confounding this relationship, right? Rather than receipt of social assistance, an alternative hypothesis might be stress associated with paying rent and threats of eviction that could be driving these trends. Now, this is fundamentally an ecologic study, so I'm not saying that that's definitively true. It's, I think, a hypothesis generating analysis that I'd really love to see more research around, interrogating what are these underlying determinants that drive this very interesting trend in overdose. So I told you I would talk a little bit about environmental influences, and I have one example from another study we did last year, which is looking at weather. This study idea came to me when I was looking at, with Jody Rich and Tracy Green, at decedent cases, people who had died of an overdose death in Rhode Island. And what we saw a lot was the medical examiner indicating respiratory diseases, COPD, asthma in particular, as two common comorbidities in these decedents. And that kind of got us thinking. Opioids fundamentally depress the respiratory system. That's essentially what overdose symptomatology is. So what if during periods of cold weather, opioid use actually has a direct biological, or what if cold weather has a direct biological impact on respiratory function, particularly in people who might have respiratory comorbidities like COPD or asthma? Could there actually be an increased risk of opioid overdose during periods of cold weather because of that biological mechanism? We also hypothesize maybe cold weather might increase one's likelihood of using alone rather than using outdoors, where people might be more likely to see you and revert and administer naloxone. You might be more likely to use alone inside, which greatly increases the risk of overdose death. Tracy, one of my colleagues in particular, also hypothesized that maybe cold weather, particularly inclement cold weather like storms, could interrupt drug trafficking and drug selling patterns, which might increase overdose risk. So we pondered this a long time. We're like, how do we actually look at this hypothesis? And what we did was we worked with some environmental health scientists, specifically Kate Weinberger, who's now at my alma mater, UBC, and Greg Wallenius, who's now at BU, to actually link information on when and where opioid overdoses are occurring in Rhode Island. And we were able to use Connecticut data with climate data that they had been using for other studies in these two states. So we had over 3,000 opioid overdose deaths in this analysis. This was a case crossover analysis. So for folks not familiar with this type of analysis, what we did was, again, knew when and where these overdoses were occurring. On the day that each opioid overdose occurred, we matched that day to a control day, a day within the same month, year, and day of the week of that opioid overdose case day. So if an opioid overdose occurred on the third Wednesday of January in 2014, we then matched that randomly to either the first, second, or fourth Wednesday in January of that year. And then we compared the mean ambient temperature on the day of the death compared to the control day, as well as the average temperature up to 14 days prior to that death. And we used a logistic regression to look at the association between ambient temperature and risk of opioid overdose death, adjusting for relative humidity and federal holidays as well. So this was exciting for me because I had never done a case crossover analysis. So it was a lot of fun to learn about this method. And also I thought the results were just very interesting. So we looked at ambient temperature on a continuous scale with cubic splines. And what I've done here is picked out one value, which is when the average temperature was 0 degrees compared to the average temperature in Connecticut and Rhode Island, which is 11 degrees Celsius or about 50 Fahrenheit. And what we actually found was this really interesting relationship. The temperature on the day of the death didn't actually have any relationship with the risk of death. You can see that at the top of the figure. We think that's because of misclassification. The medical examiners don't have to estimate when the overdose actually occurred. Some people are found many days after they in fact have experienced an overdose. But then what you see is a statistically significant relationship whereby periods of cold weather, that is 0 degrees or lower, for especially say 4, 5, or 6 days prior to the death, increased the risk of opioid overdose death by about 30% compared to periods that on average were at about 50 degrees Fahrenheit. So providing some evidence, some signal there that yes, in fact, there might be that relationship. And for the reasons, we don't know. And I'd love for more folks to have a look at this, particularly in cold environments, maybe in Vermont. But I think a nice signal here that really I'd love to see further investigation of. Okay, so I want to move now to some strategies to reduce overdose deaths. And again, thinking about more of this as a framework, because I don't have all the answers. And I would argue anyone who thinks they has all the answers to bend the curve of that major crisis is either not being genuine to you or is oversimplifying the problem. So I've spent a lot of time thinking, what is sort of a foundational framework we could use to move forward? So this is my attempt at that. So here we go. So I got a background in applied mathematics and biophysics, so I like to kind of think about things mathematically. And this is my attempt at really maybe oversimplifying the problem. So if we think about what are the fundamental drivers of overdose death, which is shown by the variable D here, sort of fundamentally a function of three things: the number of people who are at risk for overdose in any given year, the average risk of overdose among those people per year, that's beta in the equation, and because not every overdose is fatal, the risk of death conditional on overdose per year. And those three values in totality, when multiplied together, would give us an estimate of the number of overdose deaths per year. It's very, very challenging to estimate each three of these terms. And I thought a lot about how we could actually identify whether that exponential trajectory is a function of one or all of these terms changing. And I've not thought of a way to do that. So maybe an interesting discussion point. But what I have observed, if we buy this framework, are a couple of principles. The first is that each term is equally important. What I mean by that is that if you could reduce the number of people at risk of overdose by 10%, that would have the same overall impact as reducing the risk of overdose among those people by 10%. So in a way, when we get to the COVID portion, I think what we want to think about here is what term can we impact the fastest right now that we're in such a crisis. The other principle is that we ideally want to design interventions to impact more than one term. We want synergy in our approaches, right? That would be ideal, where we have an intervention that could influence N, beta, and mu. What we don't want are interventions that are antagonistic, that decrease one term, but increase another. And unfortunately, we have lots of those. Great examples would be many of our sort of well-meaning supply reduction interventions. We want to restrict prescription opioid. We want to restrict opioid prescribing rates. So we're trying to pull down the number of people exposed to prescription opioids. But what we know that actually did, in fact, was move some people who were using prescription opioids into the illegal market, which effectively increases the beta. It increases the risk of overdose because using products from the illegal market is in general more dangerous than prescribed medications, right? So we tried to decrease N and we actually increased beta and probably mu as well. So we want to ideally avoid those things. So this is kind of one way to think about it, right? Is that we've got various approaches and a lot of us in this field debate on and on about which is going to be most effective. What I'm arguing is that ideally they should all work together, right? Prevention, treatment, and recovery, all of those types of interventions are trying to decrease the number of people at risk, which we do want. We want fewer people exposed to opioids. So there is a role for prevention. There is a role for treatment. There is a role for recovery, keeping people in recovery and avoiding return to use. But there's also a role for naloxone and rescue, right? If an overdose happens, we want to reduce the risk of death, and we do that by administering naloxone and other rescue approaches. So that's important. And then also harm reduction has a role as well. Modality is what I'll talk about at the very end if there's time. Fentanyl test strips, supervised consumption facilities basically aren't necessarily trying to affect the number of people who are at risk, but it's trying to reduce the risk of overdose among those people. So All of these, I think, have a role to play, and we need to spend more time thinking about how they can work together and less time in conflict. So in the last couple minutes here, I want to just talk about a few insights that I've learned from some research that we've been doing on Rhode Island on the treatment side and on the harm reduction side, and then I'll wrap up. So on the treatment side, one way I think it's helpful to think about this is a cascade of care for opioid use disorder. We published this paper now a couple of years ago. This is getting a little bit old, looking at how people are engaging with our treatment system. This is specific to medications for opioid use disorder, methadone, buprenorphine, and naltrexone. And we used state administrative databases for those three middle histogram bars, and then federal surveys to estimate the number of people at risk. That comes from the National Survey of Drug Use and Health. And the estimated number of people in recovery in Rhode Island, that comes from the National Recovery Survey. So what you can see here is major gaps, right? We believe that about 47,000 people are at risk for opioid use disorder. They're using opioids extramedically, or they're purchasing heroin or illegal opioids on the street. We know from our all-payer claims database that in 2016, about 26,000 people received a diagnosis for OUD, and only about half of those actually initiated a medication. Now, medication is not the only pathway to recovery, I should say, but this still shows that we have a lot of ways to go in screening for this disorder, and then also providing easier pathways to initiating treatment for individuals who have been diagnosed. We've done a lot of work on trying to understand why we see this drop off, and a lot of other fantastic researchers have done this work as well. What's really alarming to me is that there are huge racial ethnic inequities in this cascade of care. So I think that's the next step, is to map those and untangle those. We know from research that even among people who are diagnosed in commercial claims data, people of color, particularly African Americans, are significantly less likely to initiate a medication in a timely manner. And that's due to reasons that are structural and systemic. We've shown that buprenorphine providers, for example, are less available in heavily segregated minority communities, and providers are less likely to offer these medications to their Black patients. So we have a lot of work to do to improve this care continuum, particularly for racial ethnic minorities. So I think, given time, I wanna actually pass on the harm reduction work I've been doing on fentanyl test strips, but a bit too overexcited there. I'll just finish with a couple of thoughts on the COVID pandemic, and then we'll have some time for questions. So I think with overdose and COVID, what I'm seeing is a ton of hypotheses right now, and we need more research to understand what is actually driving. It's probably a mix of these mechanisms at the end of the day. We don't really know, I would argue, which are sort of the primary or fundamental drivers of the trends that I'll show you we're seeing. COVID-19 could be changing the drug supply, could be disrupted. That could be leading to broader penetration of fentanyl, for example, and other products. There could be less access to services and supports for people who use drugs. Syringe service programs have been closing or providing limited services. People have been experiencing high rates of discontinuation of addiction treatment and a return to use among people in treatment. And then a huge number of stressors, right? Unemployment, financial losses, eviction, as I mentioned, isolation, depression, leading to increased use of substances. And then I think at a more proximal level, just an increase in the number of people using drugs in private and alone. I think that could be a proximal driver, definitely, that we're seeing. So what is the data actually showing? Well, there's a lot of studies that are coming out that help us understand maybe what are some evidence to support those hypotheses. This was a nice study that just came out from Kentucky, looking at EMS data, showing increases in EMS runs for opioid overdose during that initial COVID lockdown. That's that first figure. And what really shocked me, that bottom figure, was a 70% increase in runs with refusal to transport. That means people were attended to by EMS, but then refused to go to the hospital, which is a problem, particularly for fentanyl overdoses because of the complex symptomatology of fentanyl overdose. The recommendation is that even if people have been revived with naloxone on scene, they should still receive care at a hospital, ideally. And what's not shown here, but I think also was alarming, is that there was a 50% increase in suspected opioid overdose runs where the EMS arrived and the individual was already pronounced dead on arrival. And so that suggests to me evidence of a significant increase in using alone, and in the absence of individuals who could administer naloxone in the event of that overdose. So to finish here, we're seeing similar data here in Rhode Island. This is data that was just presented last week at our state overdose task force. So you're seeing the most recent data we have from Rhode Island. This is showing fatal overdoses by month from 2014 onwards. We have data confirming in 2020 up to and including September. And so what this shows is the number of deaths from January to September for each year. And after several years of small decreases, we see this massive, more than 30% increase in overdose deaths this year. It's a huge problem in our state and in many others as well during the COVID pandemic. And we're just starting to understand why. So I'll show you just sort of a quick summary of hot off the press results. We've been doing these analyses with our state Office of Health and Human Service. We've been looking at the characteristics of people that died between January and August 2019, about 206 deaths, as was shown in that prior figure, compared to the 264 deaths that were observed between January and August. And just a couple of things maybe to provoke discussion. What we're seeing actually is that nearly all of the increase was among men. Among the 58 additional deaths that we're seeing in 2020, 55 were among men. And many of those men had had prior diagnoses with depression or anxiety. This is from our all-payer claims database and our Medicaid databases, where we're able to look at a prior history of these diagnoses prior to overdose. And particularly men in their age 50s with anxiety, that's where we're seeing sort of a significant increase. And in terms of the environment, just like that Kentucky study, a smaller increase in the number of decedents who are pronounced dead at home. And then sort of looking at the cause of death, actually sort of proportional increases in all causes of death. Fentanyl playing a major role, increases in cocaine, amphetamine, alcohol, sort of increasing a broad mix of polysubstance use, but also continuing fentanyl involvement, small decreases in heroin as well. So that's what I have. I hope this has been interesting. I wanted to acknowledge the wonderful staff I have and the students who led much of this work, and our key agency partners who we get to collaborate with on a daily basis, including the Rhode Island Department of Health, the Health and Human Service, and our Behavioral Health Agency, and some of my key collaborators as well, and also funding. We have a COBRE on opioids and overdose to Rhode Island Hospital that supported some of this work, and also some other grants as well. So with that, I wanted to leave around 10 minutes for questions. I didn't get to talk about the fentanyl test strip study, so I can hit on that if you like. You can feel free to contact me by email as well. We just launched a new rebrand of my lab, so you can check out what we're doing on Medium or Twitter as well. So maybe I'll leave it there, and I'm happy to answer questions.
Brandon, it's an outstanding talk. Thanks so much for that. You have three questions. You should see a Q&A button right at the bottom of your screen. If not, I can read them to you.
I can't
Okay.
pull it up. Would you mind reading them, Stephen? Yeah.
So starting with the first, did the list of opioid manufacturers take into account for the fact that many pharmaceutical companies do not just manufacture opioids, but other necessary medications, and directly implicate only those payments regarding opioids only, or just companies that also happen to make opioids?
Yeah, great question. Thanks for giving me the opportunity to clarify. The open payments database is just incredibly detailed. Basically, how it works is it provides for every provider a listing of the transfer of value, let's say a speaking engagement, and then what company was hosting that speaking engagement and the specific product that was marketed or products that were marketed at that engagement. So we were able actually to restrict our analysis to transfers of value that were tagged as being specifically prescription opioid related. We removed we removed transfers of value that were related to buprenorphine. Methadone is pretty uncommon. And we removed any research transfers of value. You know, lots of companies sponsor research. We excluded all of those. So we were just looking at transfers of values that were specific to opioid products, you know, at specific types of, say, events, honoraria, free meals, etc. Does that answer the question?
So another, Brandon, this is complimenting you on a great talk. Thanks. I'd be interested in hearing about the fentanyl strip. So maybe you could say a little bit about what your group is up to in that area.
Sure. Yeah. Thanks for the opportunity to do so. So I've got a longstanding interest in harm reduction. I actually did my PhD working on the scientific team that evaluated a supervised consumption site in Vancouver. So I didn't talk about that today, but I have a lot of interest in that. And through those collaborations in Vancouver, they had started using these fentanyl test strips in 2017, 2016, which are like almost like pregnancy tests. They're designed originally to test for fentanyl or its metabolite in urine, but urine is mostly water. So it turns out you can actually use these strips to identify very small amounts of fentanyl in drug samples dissolved in water. And so we were able to receive pilot funding from Brown actually to do a pilot study where we enrolled about 100 young people who use drugs and brought them in, trained them how to use the strips, and then distributed 10 strips for them to use prior to consumption on their own. We didn't have any drugs on site. I always like to clarify. And then brought them back for follow-ups. And what we found was really encouraging. About over 90% used at least one of the strips. So people really liked them. They used them. They used them in a number of contexts and to test a number of different drugs. And about half of people who used them got a positive. And what we found was that a positive result was associated with about a 68% increase in what we called protective overdose risk behaviors, mostly things like using with people around you, making sure naloxone is nearby, using less or staggering use with others. We had a number of different sort of harm reduction practices that we encouraged people to use that we've refined. But we were very encouraged by the findings, and I was actually able to use that pilot data, and I received last year an R01 from the National Institute on Drug Abuse to conduct a randomized trial. So we're now doing a full efficacy trial of 500 people who use drugs and randomizing half of them to receive fentanyl test strips and a motivational viewing piece to encourage use of the strips, and then the control group receives naloxone, more of a standard overdose prevention naloxone distribution. And then we're able to link their data with the state overdose surveillance data sets to look at rates of fatal and non-fatal overdose in each of those groups. So that's very exciting, Stephen, and that work has been interrupted by COVID-19, but we're still recruiting, and you know, hopefully we'll learn more about that as time goes on. My hypothesis is that fentanyl test strips are going to be most useful for people that don't want opioids, people that are primarily using stimulants, younger people. I'm sort of anticipating not universal benefit. We powered the study to try to see if we could detect specific subgroups of people who use drugs who benefit the most from fentanyl test strips. So that's the hypothesis going in.
That sounds like a great hypothesis. So here's another specific to rural areas. Let's see if I can find it. They're rolling in here. So when it comes to rural communities, as far as epidemiology goes, is it fair to claim that substance use disorders / opioid use disorders behaves as a contagion?
Oh, wow. Such a good question. Yeah, I thought a lot about this because when you look at that exponential curve, right, there's some things that cause exponential growth. One of them is an infectious disease context. We see a brief period of exponential growth in an entirely susceptible population when you introduce a disease and it's uncontrolled. So I've wondered that if part of what's driving that is sort of a contagion effect. And I'm not convinced it is, honestly. We do have a student who's looking at that actually in the fentanyl test strip trial, and we'll be asking people about overdose in their networks and whether that increases their own risk of overdose. The literature is, to date, in my view, is unclear. It's possible that there could be an increased risk. Someone in your network overdoses, that's traumatizing to you, that increases your use or your risk. It could also be protective. It could be like a wake-up call. You know, it sort of brings the risk closer to home, so to speak. And so it could actually operate as a protective function. So we don't really know, I would say, especially in the modern era or in rural settings, how overdose is sort of permeating through social networks. So I would really love to see more research around that issue. I think that's an important one, particularly, as you mentioned, in rural contexts. Yeah, so a great area for future work.
Wonderful. So maybe a final question here. I'm interested to hear about harm reduction. More specifically, what trends we see in countries that decriminalize and regulate opioids and how this impacts overdose rates. Thank you for this great presentation.
Yeah, good question. So, you know, the classic example that we turn to in the field is Portugal, which decriminalized drug possession and has a system of engagement in care rather than arrest and charges. That's sort of oversimplifying, but so they're sort of held up internationally as a model, and they do see among the lowest fatal overdose rates in Europe from what was once a very, very high place. So a lot of us do turn to that sort of model that is kind of, if you think about that curve, more towards what we might see as a minimum. I think what I like to highlight is we're in a US context. We have a non-universal healthcare system, and we have examples, like I hope I've convinced you, where if there are actors that are operating really with a profit motive in mind exclusively, we can see great harm. And we've certainly seen that in the case of other substances as well, like tobacco. And so I think it's important to keep in mind that the transfer of, say, what's happened in Portugal into the US, we just need to be careful because it's a different context. And by no means would I recommend sort of, you know, legalized, totally unregulated access to all of these types of substances. I think we need to do a lot of work in this country to understand at least how to bring us away from those polar maximums to a more responsible and evidence-based public health approach. But what that actually looks like in this country, I can't fully answer for you. And I know there's probably a lot of other people who are thinking of that, so I'm interested in their thoughts too, but maybe that's for another day and another discussion.
Okay, well, I think with that, we're just about out of time. So I want to thank the audience for being with us. And Brandon, I want to thank you for sharing your work and for taking on this important area of research. You're doing a wonderful job. I was extremely impressed. Well, thanks to everybody, and that wraps things up for today.
Thank you, Brandon.
Thanks so much, everybody.